Hi, I'm Dr. Chen. I'm one of the full-time glaucoma attendings at Mass Eye and Ear. Thank you for the privilege of talking today about the optic nerve. So the optic nerve is one of my favorite topics because we as ophthalmologists and especially glaucoma specialists really need to understand what happens to the optic nerve when there's disease process, such as glaucoma, the #1 cause of irreversible blindness in the world. And then we as ophthalmologists really need to know how to best examine the optic nerve in the clinic. And then, of course, we all have optic nerves, so it's really interesting also to know what the normal optic nerve does. So with that, I'm going to talk about, for the next hour or so, two things. The first part of the talk is optic nerve anatomy, optic nerve function, and optic nerve pathology. And then the second half of the talk is going to be how can we best examine the optic nerve in the clinic. So for the first part, optic nerve anatomy. So all our optic nerves, of course, are like a cable that connects the back of the eyeball to the brain and the back of the head. And it's interesting that, like our friends, the optic nerve actually has a telephone number. Now, it's important to know the telephone number of the optic nerve because it actually means something. So the telephone number, the 7-digit telephone number is 125-1010. And these digits in the telephone number denote the length of the optic nerve in different parts of the head. So the intrascleral portion is the 1 millimeter portion in the sclera of the wall of the eye. Then the next portion of the optic nerve is the intraorbital portion, which is the redundant portion of the optic nerve, so meaning it has some give, like an extension cord. It's nice if it's a little longer than you need it to be, but it's 25 millimeters, so it's longer than it needs to be, because obviously this protects us from having certain problems with certain diseases. And interestingly, the intraorbital portion, meaning the back half of the eye here, the optic nerve, is about the same size as the eyeball itself, which is also around 20 plus millimeters. And the intracanalicular portion of the optic nerve is about 10 millimeters. This is the part in the bony canal. And the intracranial portion of the optic nerve is the last 10 millimeters of the optic nerve. So the intrascleral portion is the part inside the sclera. The intraorbital portion, again, is the portion of the optic nerve in the orbit. So this is the bony orbit. The intraorbital portion is the optic nerve here, here, and here. That's 25 millimeters. Now, luckily for us, the optic nerve here is longer than the distance from the back of the eye to the orbital apex, because again, like an extension cord, it's nice if it's a little longer than it needs to be, because if anything pulls on the optic nerve, like thyroid ophthalmopathy or some kind of lesion in the orbit, it's nice if when the optic nerve is on stretch, it doesn't snap. The intracanalicular portion of the optic nerve is the portion of the optic nerve in the bony canal. So which bony canal are we talking about? We are talking about the sphenoid bone. That's the yellow structure here. This, of course, is our favorite atlas and netter. But the sphenoid wing has a lesser wing and then a larger wing. So this tiny little structure is the lesser wing. This is the larger wing or the greater wing. And then the optic canal here is in the lesser wing of the sphenoid bone. And this is 10 millimeters. So again, that's a little hole here in that yellow sphenoid bone. And this intracanalicular part is important because if there's a fracture of that yellow sphenoid bone, this portends badly for the optic nerve because there's a small canal, and therefore we know that, again, a posterior orbital fracture has worse prognosis because it's more likely to damage the optic nerve that traverses that small canal. Here is the optic nerve within the back of the eye, the intrascleral portion, which has the prelaminar part, that's the optic nerve in front of the optic lamina cabrosa, and then the retrolaminar portion of the optic nerve, that's the portion behind the lamina cabrosa. So the optic nerve not only has nerve tissues or retinal ganglion cells, it has other supporting structures such as the astrocytes, that's like the mother hen of the optic nerve because it provides nutrients to the optic nerve and tries to repair it when it's damaged. The oligodendrocyte cells basically support and insulate the optic nerve like the winter jacket. And then the lamina cabrosa lends some support through which the optic nerve fibers go. So it basically organizes things as it goes through the lamina cribrosa. So again, the optic nerve is composed of nerve tissue, astrocytes, oligodendrocytes, and the lamina cribrosa. So that's the optic nerve here, not just nerve tissue, but many other things. So that's the normal optic nerve anatomy. So what are the normal functions of the optic nerve? So we all understand optic nerve anatomy in our eyes and in our patients, but what is our optic nerve currently doing? Well, aside from enabling you to process visual information, like to see me and to see this slide, and to see the brightness of all of these things, it enables us to see contrast sensitivity. So meaning the contrast between my black hair and the white wall behind me, that is an optic nerve function. So for example, glaucoma, which is damage to the optic nerve, damages contrast sensitivity. So that's why we try not to put multifocal lenses in our glaucoma patients, because multifocal lenses degrade contrast sensitivity. And the last thing we want to do is to degrade contrast sensitivity in glaucoma patients who already have a problem with contrast sensitivity. Our optic nerve also helps us to see colors. So sadly, end-stage glaucoma patients have problem with color perception. So end-stage glaucoma patients have problems on the Ishihara plate. The optic nerve also enables us to have the pupillary light reflex. It is the afferent limb, that's the optic nerve, is the afferent limb of the light reflex, which again connects to the adenoversal nuclei back to the pupil sphincter muscles, which again constricts the iris when there's bright light outside. The optic nerve is like a highway. So the main highway out of Boston is Route 93. Route 93 has a fast lane and a slow lane, the HOV fast lane in the rush hour, and then the slow lane for regular normal people. So similarly, the optic nerve is like a highway. It has rapid orthograde transport away from the cell body, has retrograde transport back to the cell body. There's a fast lane and a slow lane. The fast lane, meaning fast, like hundreds of millimeters per time unit with small molecules such as ATP. In the slow lane, large molecules and trophic factors are bigger and therefore travel in the slow lane of the optic nerve. So about a few millimeters per day. So that's the function of the optic nerve. Not only it enables us to see, but it enables to have contrast sensitivity, to have the afferent pupillary light reflex, enables us to see color, and it transports small and large molecules up and down the optic nerve. So now that we know that the nerve anatomy, the function of the nerve, we can now better understand why the optic nerve has problems when there are disease processes. So for example, when there's high intracranial pressure, this disrupts the orthograde exoplasmic flow, and therefore things back up and you have disc edema. So increased intracranial pressure causes disc edema. So that's the optic nerve telling us, or you as a physician, hey, I'm edematous, there's a problem here. Maybe I have high pressure in the brain in my patient. So why is that? Because of course the subarachnoid space surrounds the optic nerve. So if there's any issues with intracranial pressure, this evidences or manifests as disc edema. Disc swelling or disc edema can also occur with high pressure. Now, I didn't know this as a young glaucoma fellow or early attending because I remember my first acute angle closure patient. I was so proud of myself that I actually could see that there was disc edema through the cloudy cornea when the pressure was high. So I referred the patient to neuro-ophthalmology, and the neuro-ophthalmology person told me, well, Teresa, it's actually well known that when you have acute IOP elevations that there's disc edema because high eye pressure disrupts orthograde exoplasmic flow. So it is well reported that when you have high eye pressures with acute angle closure that you can have disc edema, which can resolve months later. So needless to say, since that first time, I have never sent an acute angle closure patient with disc edema to a neuro-ophthalmologist. I just wait for the pressure to normalize and the disc edema will go away. So now, even though high intracranial pressure and high eye pressure can cause disc edema, I, as a glaucoma physician, when I have successful trap surgery, can also cause disc edema because if my patient has overfiltration or hypotony, this can be associated not only with hypotony maculopathy, but disc edema, which again normalizes when the pressure goes up a little. Disc edema can also be caused by inflammation and ischemia. So the bottom line is disc edema is the optic nerve telling us there is a disease process going on because of disruption in exoplasmic transport up and down that conveyor belt or highway of the optic nerve. Now, we also know that the optic nerve not only has disc edema swelling, but it can have atrophy. And it's important to realize that different disease etiologies tend to preferentially cause different optic nerve reactions. So, for example, inflammation, infection, tumor infiltration, tumor compression, or ischemia more likely causes disc edema initially, or swelling, and that toxic metabolic causes increased eye pressure with glaucoma, and congenital anomalies usually cause pallor or atrophy. There's always exceptions, but here again, disc edema can be associated with brain tumors. Here you can see optic atrophy or pallor after ischemic optic neuropathy. Here you can see the optic nerve that initially starts out as disc edema, then months later can only be evidenced as optic atrophy. So again, going back here, we can see many causes of diseases causing many optic nerve reactions, but the bottom line, the take-home point is that glaucoma usually causes a specific form of atrophy called cupping. So here you can see a relatively normal cup-disc ratio with glaucoma causes progressive cupping. So again, if you see a cupped optic nerve, it most commonly is associated with glaucoma, but again, less commonly associated with other diseases. So here you can see a cartoon of a thumb pressing into the optic nerve causing beanpot cupping with glaucoma, excavation of the optic nerve head and cupping with thinning of the neuroretinal rim. Here, glaucoma, for you people who like subtleties, glaucoma very simplistically is called high eye pressure as a main risk factor, but in some glaucoma patients there can be low intracranial pressure. So the combination of high eye pressure or relative high eye pressure with relative low intracranial pressure can cause posterior laminar bowing and cupping. So again, here's histology of beanpot cupping in the glaucomatous optic nerve. So the bottom line is the most common cause of optic nerve cupping is glaucoma. However, less commonly, we should realize that cupping in our patient can be also associated with past ischemic optic neuropathy, a compressive lesion. So again, if we see cupping with normal pressures, maybe that's a compressive lesion and we need to rule out a brain tumor before we go ahead and diagnose the patient with normal tension glaucoma. Maybe the patient had past trauma or past toxicity, or maybe the patient has dominant optic atrophy. So for going trauma, here you can see, or in ischemia, here you can see a patient with disc edema in the acute ischemic phase, which months later causes atrophy and then cupping. Here you can see in a patient with trauma, 16-year-old gentleman fell off his bike, hit the eye, got hand motions vision, normal pressures, and 2 weeks later, after trauma, has a normal cup, but a few months later, this is cupping. So again, don't diagnose this patient with normal tension glaucoma with normal pressures. This patient, if you carefully evoke a good history, has a history of trauma to the left eye. And this patient initially had normal nerve fiber layer, but had progressive thinning months later. Again, this is not glaucoma, but this is cupping and nerve fiber layer thinning. Again, not from glaucoma, but from a bicycle accident. Here you can see a patient with temporal cupping due to dominant optic atrophy. Sadly, this is a 22-year-old lady, again, not with normal tension glaucoma and cupping, but cupping from dominant atrophy. Again, this is one of the most common hereditary optic atrophies, presenting sometimes when the patient's 10 years old or 20 years old, family history, genetic mutation. Again, this is not glaucoma, this is loss of vision from dominant optic atrophy. So again, don't treat this patient with glaucoma medications or glaucoma surgery. So we know that glaucoma usually causes cupping. That's the hallmark feature of a glaucomatous optic nerve. However, some glaucoma patients, not all, some can also have disc changes called disc hemorrhages. This classically is a splinter-like Duran's hemorrhage, a sort of skinny hemorrhage, usually on the superior and inferior regions of the optic nerve, and more preferentially superior temporally and inferior temporally. And again, this is a Duran's hemorrhage due to glaucoma. However, not all disc hemorrhages are glaucoma. Sometimes it can be from a hemorrhagic PVD. Sometimes they can be from diabetes or hypertension. But again, for the sake of this lecture, which is on glaucoma, we need to know that disc hemorrhages can be caused by glaucoma, and multi-center national studies have shown us that disc hemorrhages, such as the Oates study and the Collaborative Normal Tension Glaucoma Treatment Study, that these landmark studies have shown us that the presence of a disc hemorrhage in a glaucoma patient or in an ocular hypertension patient increases their odds ratio of glaucoma progression. So not all disc hemorrhage patients progress, but it increases the risk of that glaucoma patient progressing. So beware. So why do these disc hemorrhages happen in glaucoma patients? We don't know. We just know that they happen in high pressure glaucoma. They happen more commonly in normal tension glaucoma patients than high pressure primary open angle glaucoma. But why do they have this subsequent nerve fiber layer dropout? Maybe it's a compartment syndrome where the disc hemorrhage leaves focal notching. But we do know that there are vascular etiologies of glaucoma. So of course, glaucoma can be caused by the mechanical theory of glaucoma, the lamina damage, but it also has the vascular school of glaucoma, maybe due to vascular autoregulation issues. Whatever the case, we know that glaucoma can be associated with disc hemorrhages. So in conclusion, the optic nerve has a number of pathological responses, such as disc edema, disc hemorrhages, and pallor, but most commonly for glaucoma, it is cupping. The telephone of the optic nerve tells us the length of each segment of the optic nerve, 1, 2, 5, 10, 10. 1 is the intrascleral portion, 25 is the intraorbital portion, and 10, 10 is the optic nerve within the bony canal and the intraorbital portion. The longest portion being the 25 millimeter intraorbital portion. And then lastly, the optic nerve is not a static thing or structure. It has an active exoplasmic flow up and down with small and large molecules. So that's the first part of the optic nerve lecture. Again, if you have any questions, here is my email, is Teresa_Chen at MEEI, that's Mass Eye and Ear Infirmary, .harvard.edu. So the second segment of the optic nerve lecture is going to be, how do we examine the optic nerve in the clinic? Specifically, how do we discern these changes in a glaucoma patient? So I'm going to talk about how we can examine the optic nerve, features of the normal optic nerve, and features of the glaucomatous optic nerve. So how do we examine the optic nerve in the clinic? Obviously, we know about indirect and direct ophthalmoscopy, but most commonly in the clinic, we use our slit lamp with a non-contact handheld lens. I'm just going to focus a little on the ruby lens because this is not commonly used, but we usually have a ruby lens that can be attached to the slit lamp apparatus. It is a minus 55 diopter lens, so because it's a minus lens, it is a direct erect image, so meaning it's not upside down and backwards. But again, most commonly we use the 78 diopter or the 90 diopter lens. And so we know that as the power of the lens increases, for example, I like to use a 90 diopter lens, as the power of the diopter lens increases, the magnification is smaller. So the optic nerve is smaller, but I like the 90 diopter lens because I look in through a small pupil and have a wider field of view. Some of my colleagues prefer to use a 78 diopter lens because it, although it has a smaller field of view, it has a more magnified appearance of the optic nerve. So here you can see an example of the optic nerve with various sizes. So again, this is my favorite lens. Here's a slit lamp beam top to bottom, and you can see relative to the slit lamp beam, the optic nerve is pretty small. But if I use the 78 diopter lens, the nerve appears larger. But again, I like the 90 diopter lens because I can look through a smaller pupil. Here you can see the direct ophthalmoscope. It's a direct view, meaning it's not upside down and backwards. And one of the key features of the indirect view, meaning when we look with a 78 diopter or 90 diopter lens, is that we can actually determine disc size. Now this is crucial, so this is really important, but you can use that same micrometer ruler on the slit lamp. So again, we use this little ruler to measure corneal abrasions and things, but we can use it to measure the disc size. So if you adjust the slit lamp beam so that matches the top and the bottom of the disc, then you take that size off of the micrometer and you convert that. So let's see, whatever that size is, multiply by 1.33. Again, if you're using a diopter lens, that's the actual size of the disc. We're going to talk about imaging in another lecture, but suffice it to say you can objectively quantify and look at the optic nerve in the clinic with most commonly OCT. But again, we'll talk about that in a different lecture. So again, you can look at the optic nerve with a 78 diopter and 90 diopter lens, but you should know that there are other ways to look at the optic nerve, such as with the direct ophthalmoscope or the indirect ophthalmoscope, or even the ruby lens. Now, what are features of the optic nerve? Well, the optic disc has certain size, shapes, and surrounding peripapillary atrophy and surrounding nerve fiber layer. So the disc is sort of like an upstanding or erect or vertical oval, so meaning it's longer vertically and shorter horizontally. And the average disc area, which is not commonly known, is about 2.5 plus minus square millimeters. So that's, I remember 25, like a quarter. So square millimeter, 2.5 square millimeter. And again, we know it's a little more than 1.5 millimeter in diameter. So certain diseases are more evident in certain disc sizes. So for example, we know, again, a quarter, 2.5. The normal eye is around 2.37 square millimeters, or 2.5 for easy memory. And that larger discs are associated with pits and morning glory, and smaller discs are associated with drusen and papilledema. So again, the disc at risk, again with non-arteritic ischemic optic neuropathy, slightly smaller disc size. So here you can see smaller discs with drusen. You see it looks really small, disc diameter. Morning glory, this looks really big. So if we take our micrometer and measure the disc diameter, it would be pretty big. It would be more than 2.5 millimeters square and much more than 1.5 millimeter in diameter. So another normal anatomy is the isn't rule. It doesn't apply to all normal nerves, but in general, the typical neuroretinal rim is thickest inferiorly, then next thickest superiorly, then next thickest nasally, and then thinnest temporally. So in all of us, me, you, everybody, our patient, normally the inferior neuroretinal rim is the thickest, followed by number 2, the superior neuroretinal rim, then number 3, the nasal, and then here you can see the temporal neuroretinal rim is usually the thinnest. Any deviation from the isn't rule, any deviation from that is more likely glaucoma. So obviously glaucoma causes superior and inferior thinning. So if the superior or inferior neuroretinal rim is the thinnest, instead of the temporal rim, that is a red flag and saying, well, maybe that patient has vertical cupping or glaucoma. So what are the features of the optic nerve in glaucoma? I sort of briefly mentioned the classic feature, which is vertical cupping. But it's important to realize that certain features of the optic nerve are important, such as disc size that we mentioned, which we can measure with a micrometer, rim integrity, which we mentioned, RNFL integrity, and disc hemorrhages. Those are key. If you remember those 4 things, you can understand the glaucomatous optic nerve. Less important, which I'll touch upon, are tilt, shape, laminar visibility, peripapillary atrophy, and cup depth. So disc size. So here is a patient with a small disc area, 1.3 square millimeters, And here's a patient with a large disc area, over 3 square millimeters. Now this makes a difference because if you have a small optic nerve, those 1.2 million axons have to squeeze through a smaller scleral canal. So here's a patient which has a small optic nerve disc diameter, had high pressures in the 40s, lost a follow-up for 3 years in the right eye. And here you can see that right eye, which used to be 0.1 cup-disc ratio, now has maybe a 0.3 cup-disc ratio. But again, in this patient, since they were born with a 0.1 cup-disc ratio, 0.3 is glaucomatous. So everybody has a different cup-disc ratio baseline, and glaucoma by definition is a progressive optic neuropathy, meaning our patient's cup-disc ratio is progressed or worse from their baseline. And if you have a small disc, you usually have a smaller cup-disc ratio at baseline. So here you can see that most of us are around this area, like around 2.5 square millimeters, and some of us have smaller disc diameters, some of us has larger disc diameters. So here is an example of a patient with a large disc diameter or megalopapillae. But again, those 1.2 million axons can spread out and be totally intact, and all 1.2 million of them can be in this large scleral canal, and therefore that patient is entitled to have a large cup. But again, this is not glaucoma. This is simply someone with an ethnically large normal disc diameter. So disc tilt is not that important. You know, if you're myopic, you might have a disc tilt, but this doesn't necessarily mean you have glaucoma. Of note, a slight tangent, if you have myopia, very, very rarely your tilted nerve can cause visual field defects that are unrelated to glaucoma. But again, this is super rare. Disc shape, if you have a sort of rounder optic nerve, a more vertical nerve with some temporal tilting, or if you have a more tilted nerve this way or more oval, it does not matter the shape of your nerve. You can have any shape of optic nerve you want, whether you're normal or glaucoma, so disc shape is not important. Here is a patient with a rounder right optic nerve and a more oval left optic nerve, but both optic nerves are normal and non-glaucomatous because the visual fields are normal. They just happen to have different optic nerve shapes and sizes in the two eyes. So it's like one of those patients who have different shoe size on one foot than the other. Doesn't mean that they have any pathology. That's just normal differences on both sides of their feet. Similarly, patients or we can have some normal asymmetry in our optic nerves. Again, not that common, probably 5–6% of the normal population, but it can happen. Cup depth. This, of course, is not a hallmark feature of glaucoma because here you can see a patient with cupping on OCT, but it may be due to physiologic cupping or glaucomatous cupping. So again, cup depth is not that important. Rim integrity is important because, as we know from the isn't rule, that thinning of the inferior and superior neuroretinal rim is a classic feature of glaucoma. So if your superior and inferior neuroretinal rim is thinner than your temporal rim, that's bad, and that could be suggestive of glaucoma. So here again is superior and inferior or vertical elongation of the cup. Here you can see inferior thinning, where the vessels are just basically sitting right on the disc border and there's no neuroretinal rim down here. Maybe there's some orange neuroretinal rim up here, but again, no neuroretinal rim down here. Here you can see the opposite. Here's a patient with almost no superior neuroretinal rim and a pretty thick inferior neuroretinal rim. Again, that's classic for glaucoma, superior or inferior neuroretinal rim thinning. So rim integrity is very key in the diagnosis of glaucoma. The optic nerve exam is crucial. The nerve fiber layer exam is also crucial. So if you're looking at your patient at the slit lamp or with your indirect, here you can see the right eye, left eye. Normally the nerve fiber layer is very shiny and bumpy white here, reflective. However, when the nerve fiber layer, the top layer of the retina, thins with glaucoma, here again, here's a nerve fiber layer that spans the back of the posterior pole, has this arc pattern, It's more dense here and dense on the top and the bottom. However, with glaucoma, you can see where the disc hemorrhage, there is some thinning. And when the nerve fiber layer thins, it has two features. One, it loses this shiny white reflective appearance, and two, it's instead of bumpy like beads of rice on a countertop, it is flat and smooth like a countertop. So again, two changes, loss of reflectivity, and it's more smooth and less bumpy. So here you can see on red-free photography, glaucomatous dropout of the nerve fiber layer and the arcuate pattern, where there's two changes, loss of reflectivity and more smoothness. Here you can see loss of reflectivity and greater smoothness. Here you can see in glaucoma, loss of reflectivity and bumpiness. Here you can see loss of reflectivity and smoothness in glaucoma. So normal, glaucoma. Here you can see diffuse atrophy, where a normal, highly reflective nerve fiber layer, moderate glaucoma and advanced glaucoma with diffuse dropout. And again, two features, loss of reflectivity and two, smoothness. So again, nerve fiber layer exam, very important when you look at your patient with either your 78 or 90 diopter lens or with red-free photography or the red-free light on the slit lamp. Laminar pore visibility is not that important because, again, you can have physiologic cupping with good visualization of the laminar pores, and you can have glaucomatous cupping with great visualization of the laminar pores. Here, that was an example of physiologic cupping with great visualization of the laminar pores with a normal visual field. So again, visualization of laminar pores can be associated with normal patients as well as glaucoma patients. So not that important when you're busy in the clinic. Just don't pay too much attention to laminar pores. Here on OCT, you can see the black little laminar pores on the picture here. So peripapillary atrophy, I wouldn't spend too much time in the clinic if you're busy, because peripapillary atrophy can be seen in normal and glaucoma patients, although it's very important to realize that the area of peripapillary can increase with worsening glaucoma. But again, not something that you need to focus on in the glaucoma clinic, because again, normal people have peripapillary atrophy. So sometimes peripapillary atrophy is normal, sometimes it's pathologic. Here you can see in this case that peripapillary atrophy was associated with glaucoma. So asymmetry can be normal or glaucoma, and again, we'll talk about that later in the talk as well as in the imaging talk. But subtle cup disc asymmetry is normal in 5–6% of the normal population. Here again, some normal cup disc asymmetry with normal fields and no glaucoma. Again, that's only 5–6% of the normal population who has cup disc asymmetry of 0.2 or more. But it's also important to realize that cup disc asymmetry and Arnefel asymmetry, and again, cupping asymmetry, can be an early sign of glaucoma. So in summary, disc size is important because if you have a larger disc, that 1.2 million axons can spread out, and some people, such as Hispanics and African American, normally have a larger disc, and that's why for them, a 0.6 cup disc ratio can be normal. However, in a Caucasian hyperopic lady who may have a small disc of 1 millimeter, she probably should have a cup disc ratio that normally is 0.1, because again, she has a small disc. So those 1.2 million axons have to cram into that small space, and there's no room for the cup in that small space. Rim integrity is crucial in your clinical exam, because if you see thinning of the superior inferior neuroretinal rim, that could be glaucoma. If you see two changes of the nerve fiber layer, the retinal nerve fiber layer, meaning if you see loss of reflectivity or smoothness of the nerve fiber layer, that's not normal, that could be glaucoma. If you see a disc hemorrhage, that probably is not normal. That probably is glaucoma. But again, be aware that things like PVD, diabetes, and hypertension can cause disc hemorrhages, although not in that classic glaucomatous Drance-like splinter linear fashion at the superior and inferior pole of the optic nerve. So in summary, we should realize the normal clinical appearance of the optic nerve. We need to correlate our optic nerve exam with clinical testing. So for example, it may look glaucomatous, but if the field is normal, then probably the patient's normal and doesn't have glaucoma. And then we can use other ancillary tests besides the visual field. We can use other tests such as imaging to help rule in or rule out glaucoma. So the bottom line is our optic nerve exam should focus on certain things, but that is just one piece of the puzzle, and we still need to look at the vision, the pressure, the testing, and other exam features when we're in the clinic to diagnose our patient with optic nerve disease and glaucoma. And most importantly, if you're not sure if your patient has glaucoma at that point in time, it's important to realize the definition of glaucoma is a progressive optic neuropathy. So untreated, glaucoma is not static. If the patient's cup disc ratio changes from 0.1 to 0.3, that's glaucoma. So progression is the key to diagnosing glaucoma and to diagnose progression. So again, if you have any questions about the optic nerve, the anatomy, normal things or normal or pathologic process, if you have questions about how to better examine the optic nerve in the clinic, please feel free to email me at teresa_chen@meei.harvard.edu. Thank you so much for spending the time with me, and I hope that this has been helpful. Best wishes in your career.